Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational webinar titled Racial Disparities in COVID-19, Causes, Consequences, and Clinical Strategies. During this podcast, Drs. Oni Blackstock and Harawa discuss healthcare inequities that lead to racial disparities in COVID-19 outcomes, as well as strategies to overcome barriers to optimal COVID-19 care. For more information on Drs. Blackstock and Harawa, and also on Drs. Mailbranch and Wallace, who collaborated on the development of this program, please visit the show notes for this episode, where you will also find downloadable slides. Now, let's get started and hear what our expert faculty have to say about COVID-19 racial disparities.
To give a brief overview of our program, we are first going to discuss a background on health inequities and how they affect Black, Indigenous, and other people of color. We will review COVID-19 racial inequities and disparities and the health inequities that drive them. And finally, we'll discuss how to overcome barriers to optimal COVID-19 care in this population. Health equity and health disparities are intertwined. Health equity means justice in health. In other words, no one is denied the possibility to be healthy for belonging to a group that has historically been economically and socially disadvantaged. Health disparities are the metric by which we measure progress toward achieving health equity. So, of course, since health equity is justice in health, health inequities are the opposite. Over the past several years, there have been more and more attention to the role of social determinants of health in creating health disparities and contributing to either negative or positive health outcomes in populations. According to CDC, social determinants of health include the conditions in which people are born, grow, live, work, and age. And this covers a number of different domains, including educational access and quality, healthcare access and quality, the neighborhood and built environment in which people live and work, the social and community context in which they interact and get information, and the economic stability of those, all of those settings and their own households. Medical racism is one of the forces that shapes social determinants of health within the healthcare system. It's defined as systematic, widespread racism within the healthcare system toward people of color. On the left are well-known historical abuses that have spawned this legacy, legitimate distrust in healthcare and government among Black and Indigenous people of color. And one of the points we want to drive home today is that that distrust is well-grounded in a number of different aspects of both history and current context. That legacy includes Miss Henrietta Lacks, a mother of 5, who died of cervical cancer at Johns Hopkins Hospital and had cervical cells removed from her both during life, her dying process, and after death without the permission of her family for them to be used in research. These led to the first perpetual cell line called HeLa that has since been key to countless developments of health and healthcare, and also huge amounts of revenue for new drug treatments. Next is the U.S. Preventive Health Service syphilis study. This is often called the Tuskegee study, but it's important to keep in mind that it was a U.S. Preventive Health Services study, which is now the CDC. This study involved 399 Black men who were enrolled for over 42 years, and in over 30 of those years, those men were not given treatment for syphilis and were actively prevented from getting that treatment through a number of different means. And finally, there's the eugenics movement, which I will touch on in the next slide. But I think it's important to point out that even if someone knows nothing of this history, they may experience directly or indirectly discrimination and medical racism in the healthcare setting. And by indirectly, I mean those vicarious experiences that people see their loved ones go through, either with discriminatory practices or implicit and explicit bias. This set of things that contributes to healthcare inequities and racial disparities in terms of COVID-19 outcomes and vaccine-related concerns. There's also ongoing medical coercion. This starts with the history of eugenics, which among other things involved forced sterilizations that largely targeted BIPOC communities and disabled communities. This sort of period of eugenics began in 1907, and I think most people are aware that it existed in the early 20th century, but maybe not that it continued for the subsequent more than 70 years. More recently, we have more subtle but still important examples of coercion. First evident in the rollout of long-acting contraceptive implants. For example, there were bills proposed by states that actually incentivized the use of these implants for people on public assistance, and at least in one case mandated their use for women on Medicaid who had had an abortion. Further, Medicaid, when Norplant first was rolled out, Medicaid only reimbursed providers if the contraceptive implant stayed in place for 5 or more years. But this even exists today, this particular example of medical coercion, because Medicaid reimbursement for removal of IUDs, another long-acting contraceptive, varies by state. And in some states, IUD insertion is covered, but early removal is not covered, even for women who have adverse effects from their IUD. Inequity in pain treatment is another well-documented example, and one that I find particularly problematic and degrading, because denying or undertreating someone's pain is really a denial of their humanity. Research has shown that in patients in emergency departments, Black people receive fewer analgesics for bone fractures than do whites. It also shows that one of the most serious experiences of pain, metastatic or recurrent pain, that among people experiencing that type of pain, BIPOC patients are less likely to receive guideline-based prescriptions for analgesics. Hispanic Americans have been shown in research, those who have chronic pain have been shown to have less access to pain treatment compared to non-Hispanic individuals that are living with chronic pain. And finally, there's research with Indigenous peoples in rural and tribal regions indicating that they frequently lack access to pain management providers, and report that when they are able to see those providers, they often have their pain ignored, undertreated, or overlooked. And I want to point out that these are just a few examples. There are numerous other examples of biased and discriminatory care within the medical system. Another thing to keep in mind is the actual context that's experienced by people of low income and those experiencing homelessness. And these groups are also disproportionately BIPOC individuals. There's common characteristics of these facilities that do not necessarily support a good experience of those facilities. Homeless populations are often served in mobile facilities, and other low-income populations often get their care at a distance from their place of residence. It's been shown that Hispanic and Black populations travel on average farther for healthcare than do whites. Oftentimes, people only get care in these groups if it's an emergency, so then they're experiencing a certain type of often crowded and chaotic environment in which they may be getting care. Many settings that provide care to low-income people have a security or police presence, which again may not provide a welcoming atmosphere to people with negative experiences with police enforcement. And often there's a lack of privacy and crowded conditions in these spaces. It's also important to keep in mind that this group is disproportionately likely to have healthcare experiences that are non-voluntary or coercive. I already talked about some examples of coercion related to birth control, but it's also important to realize that in medical settings, there may be collusion with law enforcement. That may be to report people to DCFS or other types of collusion. There's reporting of communicable diseases that are more common in this group, as well as treatments that are sometimes stigmatized, like methadone treatment, for example. So I started this segment by giving some definitions related to health equity, health disparities, and health inequities. And I will close it by talking a little bit more about terminology that's commonly used to describe the healthcare experience of BIPOC populations. Now, mistrust and distrust are both used in this context, but there's been a move towards using the term distrust because the phrase medical mistrust connotes a lack of trust that is unsubstantiated, whereas distrust is understood to be grounded in real experiences. Disparities versus inequities. The commonly used term disparities means disparate, different, or different, but it doesn't necessarily imply a cause. Inequities, again, go back to that idea of health justice and are the unfair conditions that cause health disparities. And I already pointed to many of those social determinants. And finally, vaccine hesitancy, and I'll add vaccine resistance or understandable reluctance. It's important to keep in mind that both historic and medical racism should be recognized as a valid cause for concern among BIPOC populations. And with that, I'd like to shift the presentation to Dr. Blackstock, who's going to talk about COVID-19 racial disparities.
Thanks so much, Dr. Harawa, for setting the stage and for the foundation for understanding health inequities, both historic and present day. Now I'll be speaking specifically to COVID-19 related racial disparities. So what are we seeing in terms of COVID-19 hospitalizations and differences by race ethnicity? This slide shows on the y-axis time since the beginning of the pandemic, and the y-axis, the COVID-19 hospitalization rate. And as you can see, among Native American, Black American, and Latino Americans, there's a higher overall rate of hospitalization, with disparities increasing as the pandemic progresses. This data shows some of the disproportionate mortality that has been observed during the pandemic. The blue bars represent proportion of COVID-19 deaths among each racial ethnic group, and the orange bar is sort of the unweighted distribution of the population or representation of the population in the United States. And as you can see, deaths among Hispanic or Latino Americans and Black Americans are disproportionate to their overall representation in the population. This slide shows the myriad treatments that we have now available to treat patients with COVID-19. This includes corticosteroids, remdesivir, and other monoclonal antibodies. And as you can see, many of these treatments are really for patients who are hospitalized with severe or critical disease. Monoclonal antibody treatment, which many of us have heard a lot about, and which can be provided for in the outpatient setting, is available, but one needs to have a healthcare facility nearby that is providing it, particularly one that is able to provide infusion therapy, and we know that that can be limited. This slide sort of speaks to that point in terms of the challenges and inequities that we see related to access to healthcare resources. So for instance, we're seeing here, looking at the average number of beds per 1,000 New York City residents, we see that in zip code areas that have majority Black and Latino residents, a much lower number of hospital beds and ICU beds as compared to majority white zip codes. We see that majority Black and Latino zip codes have higher COVID-19 testing rates or positive rates than white zip codes, but there is less access to hospital beds, which further contributes to inequities and outcomes for COVID-19. So looking even further, so digging a little deeper, looking at racial disparities and hospitalization and mortality rates, this is a retrospective cohort study that was conducted in New York City, comparing outcomes for about 10,000 patients who were diagnosed with COVID-19. The analysis adjusted for a number of potentially confounding factors such as age, insurance status, comorbidities. And after adjustment, the researchers found that both Black and Latino patients were more likely to test positive. However, they found that among hospitalized patients, Black patients were less likely than their white counterparts to have severe illness or to die or be discharged to hospice. And so from that, the researchers concluded that although Black patients were more likely than white patients to test positive, that after hospitalization, because they had lower mortality, suggested that neighborhood characteristics were explaining and sort of driving the disproportionate mortality of Black patients who died outside of the hospital. So just looking at, what are some of the causes of these racial disparities that we see in healthcare? So a number of studies have looked at this question and show that Black, Indigenous, and other people of color receive a lower quality of care than their white counterparts. And this is the case even when they have the same health insurance or ability to pay. And so the causes are thought to be multifactorial. healthcare system organization and operation where folks are lacking public health insurance, a lack of coverage for certain diagnoses. We know that Black and Latino neighborhoods, as noted on the previous slide, have much fewer hospitals and beds available to provide care. There's also a contribution from healthcare providers' biases and prejudices when treating BIPOC communities rooted in stereotypes, racism, sexism, et cetera, that then leads to poor quality of care that's given. Also, the social determinants of care include inequities that, because of sort of the treatment of BIPOC communities, there is mistrust and distrust that occurs as a result, which can then affect engagement in healthcare and adherence to treatment. Additional factors, so just thinking about COVID-19 risk, what places Black, Indigenous, and other people of color at risk for COVID-19. People of color we know are overrepresented in essential service industries that have increased SARS-CoV-2 exposure, and that's related to occupational segregation, a number of both past and present day policies that have sort of concentrated BIPOC people in certain industries, low wage jobs that are often associated with not having, employment-based health insurance, a lack of paid sick leave, a lack of childcare, and then fewer options or opportunities to work from home. And then in addition to occupational segregation that increases risk, residentially segregated settings, which have led to high housing density, so crowded homes, transportation barriers, again, multi-generational households where social distancing may be challenging, and then sort of the increased levels of chronic stress associated with dealing with structural racism on a daily basis, violence, and everyday macroaggressions and trauma. All of these contribute to placing BIPOC at increased risk. There's no genetic predisposition to COVID-19 risk. This is really about social and contextual factors that increase risk for BIPOC communities. So the first question is, your practice is in a predominantly BIPOC community. All of the following factors likely contribute to worse COVID-19 outcomes, except A, chronic stress, B, genetic predisposition, C, lack of access to hospital beds, D, increased exposure to SARS-CoV-2 at work, E, transportation issues, or F, you're uncertain. Please select the best answer. Great. So it looks like the majority of the audience chose the correct answer, which is genetic predisposition. There's no evidence to suggest a genetic predisposition is what causes these inequities in COVID-19 risk. I'm going to be just passing this back to Dr. Harawa for this section.
Thank you. So these data show COVID-19 vaccination by race ethnicity, and I think that they continue to tell the story that I painted somewhat globally. Dr. Blackstock painted with very concrete data related to the COVID pandemic and show us one example of people's engagement in the healthcare system related to COVID-19. And we see from these data the percentage of people who are vaccinated in the US population. Or let me put it a slightly different way. We see the racial distribution among those who are fully vaccinated and compare that to the US population and their racial ethnic distribution. So the slide presented slightly differently, but basically the same sort of concept that you saw earlier. And we can see from these data that whites are almost proportional to their population. There's 59% of fully vaccinated and 60% of the population. There's something of a disparity when we look at Hispanic populations. It's 16% of those vaccinated versus almost 18.5% of the population. And among African Americans, there's even a bigger disparity when we look at it relatively, where 9.2% of those who are vaccinated are African American, and that compares to 12.5% of the population. So what are the concerns that Hispanic and Black patients have about vaccination? There are several of them, but one of the things we want to point out is that the concerns for this population in many ways are similar to what are seen among white, except for there's the added concern related to actual access. and the implications of getting the vaccination on their pocketbook or on their jobs. So you can see above that among parents of unvaccinated children who were being very concerned or somewhat concerned about the COVID vaccine, it was similar numbers of Blacks, Hispanics, and whites who said that not enough was known about long-term effects, that children might experience serious side effects, that it might negatively impact my children's fertility in the future. And part of why I talk about eugenics is because of how common reproductive concerns come up related to the COVID-19 vaccine. And then there's also concerns about coercion that in this study were lower among Black parents, but higher among Hispanic than white parents. But where you see the biggest differences are things related to access. So Black parents were concerned about having to take time off work, either to get their children vaccinated or help them if they had side effects. They were concerned about the setting in which they might be able to get vaccinated and whether or not they trusted getting a vaccine in that setting. They were concerned about having to pay for vaccination, and this is a concern I also hear repeated in many contexts. And then finally, they're concerned about how far they may have to travel to get their children vaccinated. And all of these are quite a bit higher among Black and Hispanic parents than we see among white parents. But there are lots of opportunities, and I think this is the other piece that we want to drive home today, and that providers, as will be talked about in the next segment, can go a long way to addressing some of the vaccine reluctance, the understandable reluctance that we see in BIPOC communities. So in recent data has shown some movement. For example, in March 2021, there was 17% of the Black population surveyed, and 25% were either open but uncertain or skeptical about getting vaccinated. In just a month's time, that went down to 13 and 18% respectively. And then we also saw a similar drop among Hispanic patients, where in March 2021, 19% were open but uncertain, and another 23% were skeptical, and that went down to 18 and 11%. And so these are where there are really opportunities to make a change. The most resistant people, it may be harder, but we also see some movement in the right direction there as well. It's also important to point out, especially to providers, that in spite of the medical racism that people have experienced, healthcare providers do remain a trusted source of information among people who are waiting and seeing about the vaccine, including and especially people of color. So people who report being very or somewhat likely, they might turn to for vaccine information are doctors, nurses, or other healthcare providers. You see very large proportions of Blacks, Hispanics, and whites are likely to turn to providers in those groups for information. But unfortunately, much smaller portions of those populations have actually asked their doctor or another healthcare professional for information. So we see much smaller proportions here, only 33% of Black patients and 13% of Hispanic patients. But again, it's important to point out that even if a patient doesn't ask, providers can go a long way by talking with their patients about it and raising the issue with them. And so to address that, Dr. Blackstock will talk about strategy.
Great. Thank you so much, Dr. Harawa. Okay, so moving on to strategies to overcome some of these barriers, just wanting to sort of build on what Dr. Harawa was discussing around some of the common concerns that are coming up when it comes to the COVID-19 vaccine. Some of the concerns are related to how quickly the vaccine was developed. Many people thinking that it was very much quicker than they would have expected. Concerns around representation in clinical trials, whether BIPOC communities and people were represented in the trials. Concerns around efficacy, safety, and side effects, the belief that what is unknown about vaccines poses an even greater risk than COVID-19 itself. Also, challenges that many have experienced, including BIPOC communities, have been around access to vaccination services, which has improved, we know, over the course of the pandemic, but for a small number of folks still remains an issue. And then distrust in government, the healthcare system, and pharmaceutical companies, sort of building on what Dr. Harawa was mentioning previously. So in terms of addressing concerns about the development of mRNA vaccines in particular, some of the points that are important to highlight include the fact that this is a technology that has been worked on for almost 2 decades. So the NIH has been working on these vaccines for 17 years. And although the COVID-19 mRNA vaccines were the first to be authorized or approved, that this technology has been and is being studied for vaccines for many other conditions. We know now being studied for the flu and HIV as well. mRNA technology also is advantageous because it allows for rapid development of vaccines, which is perfect for novel diseases like COVID-19. And then often, in many conversations, particularly with sort of Black audiences or communities, it's often highlighted that Dr. Kizzmekia Corbett, who was part of the NIH team that partnered with Moderna to develop their vaccine, that she was a key figure in the development. And for some folks, that can be helpful information to know that someone who looks like them was also part of this process. In terms of addressing the representation of BIPOC people in vaccine clinical trials, so answering the question, were vaccines tested on people like me? We know that about a quarter of participants in the COVID-19 vaccine clinical trials were age 65 and older. A similar proportion also had comorbid conditions such as high blood pressure and diabetes. In the mRNA vaccine studies, that the representation of Black and Latino participants was similar to the representation of Black and Latino Americans in the general population. Whether these vaccines work for all racial and ethnic groups, there is strong evidence that the vaccines work well for all people, again, regardless of genetic background, that tiny differences are unlikely to impact the efficacy of these vaccines. And we know that there's, sometimes greater genetic variation between people of the same race than between people of different races. So just to highlight that point, that genetics do not play a role in this. When it comes to communicating about the vaccine and talking to patients and trying to increase their motivation to take the vaccine, sometimes we can fall into this sort of phenomenon called a writing reflex as providers. And it's really the tendency to identify a problem and then attempt to solve it for the patient without engaging with the patient, without it being collaborative. And so what this can often look like when we think about COVID-19 vaccines is, as a provider, you ask the patient why they don't want the vaccine. The patient says there are reasons for not wanting the vaccine. The provider then replies with a counter argument, and the patient then kind of digs in their heels and sort of their concerns are further strengthened. So the alternative is really what we can do as healthcare providers is really, offer our expertise, but do it in a collaborative style that really emphasizes the patient's autonomy and their right to make a final decision for themselves. So some of the strategies that we might want to avoid as healthcare professionals in these conversations is really avoiding getting into an argument, trying to convince or persuade, being dismissive, shaming we know that is not effective. And so we don't want to use shame or fear, as an appeal to patients. And instead, we want to consider really asking open-ended questions to really clarify and understand the patient's perspective, reflect back what we're hearing, and offer a positive perspective on the patient, highlight, it seems like you're taking all these different steps to stay safe. That shows that you really care about your health. So, affirming the measures they've taken and then supporting patient autonomy. In terms of strategies that can be helpful, motivational interviewing is really an approach that strives to really elicit motivation for change internally as opposed to external to the patient. It emphasizes the patient's strengths rather than their problems, and also invokes really more of a guiding style for the interaction, really engaging, collaborating, emphasizing autonomy. And some of the core skills associated with motivational interviewing are really asking permission to inform and then following up by asking about what are some of the implications maybe for the patient now that they've heard this information, asking open-ended questions that really invites the patient to think about why and how they might want to engage in this new behavior, and then really listening to understand and reflecting back and summarizing what you're hearing the patient say. The brief negotiated interview is sort of a framework that can be really helpful in thinking about how to have these conversations and uses motivational interviewing techniques that I mentioned on the previous slide. And it really helps providers to discuss health behavior changes with patients in a way that is respectful and non-judgmental and really gives the patient a voice and choice. And the 5 steps include building rapport by asking permission to discuss the topic, exploring pros and cons by asking open-ended questions, listening, reflecting, summarizing, using an approach called elicit, provide, elicit, which I'll go into briefly, assessing readiness, and then negotiating an action plan that reflects the level of willingness expressed by the patient. So step 1 in terms of building rapport and asking permission can sound like this. Mr. Perez, it's great to see you. How are you? I'm well, doc. How are you? You can say, remember from the last visit, you had concerns about COVID-19. I know it's something that you want to protect yourself from. You're now eligible for it. I'd like to offer it to you. Mr. Perez says, I'm not sure. I know there's some good things, but I'm worried. And then as a provider, you say, I understand, and ask permission. Would you be open to learning more about the vaccine today? And so that's sort of an entry point. If the patient says yes, to then share relevant information. Exploring pros and cons can sound like asking open-ended questions. Help me understand your concerns about the vaccine. Reflect key points. What might be some of the benefits that you see? And then summarizing. So on the one hand, you said XYZ are your concerns, but on the other hand, you see XYZ as potential benefits to getting the vaccine. Next would be providing information using an elicit, provide, elicit approach. So, once they've shared their pros and cons and you summarized it, saying, would you be open to my sharing some details with you? Or would it be okay if I tell you what we know? So eliciting permission, then providing information, research suggests, studies have shown. And then once you share that, say, how does that impact your decision? Where does this leave you? So really eliciting a response from the patient once you've shared information with them. And then assessing readiness for vaccination. You can say something like, now that we've had a chance to talk about the vaccine, where does this leave you in thinking about having your first dose today? And if they say, yes, they're interested, that's great. You've made a decision to go ahead. Or if they're like, I'm not sure, you could say, I'm glad that you're considering it. And if the patient is not interested, leaving the door open, I can give you some information to take home. Can the nurse call you in a week or two to answer any questions? What sounds best to you? And then lastly, negotiating an action plan based on the actual degree of willingness expressed by the patient. So the patient wants to get vaccinated, letting them know the nurse will come in to administer the vaccine. If they're considering again, may we call you to remind you about coming in? And then if they're resistant or just not interested, may we talk about this decision the next time you come in, or can I give you a call to talk about it? So moving to our assessment question, when offered the COVID-19 vaccine, your patient expresses concerns about its efficacy among people of her race ethnicity. If using the brief negotiated interview, how should you respond? A, good question. Thankfully, there's no cause for concern since the vaccine clinical trials included different races at approximately their distribution in the population. B, I understand. Did you know the benefits of the vaccine have been shown to outweigh the risks in every group? C, don't worry. I won't try to force vaccination on you. It's totally up to you if you decide if you want to protect your health. Or D, I understand. Would you be open to learning more about the vaccine today? And then E, I'm uncertain. Please vote now. Great. It looks like the majority of the audience chose the correct answer. I understand. Would you be open to learning more about the vaccine today? So really, again, asking for permission before you share information can be incredibly helpful for patients. And yes, so a hallmark, asking permission to provide information. And so the take-home points are really to recognize that healthcare inequities are really the drivers of racial disparities in overall health. And we want to work to overcome the barriers to COVID-19 testing, prevention, and treatment among BIPOC in order to eliminate inequities. And that the message and messenger matter, that BIPOC scientists and healthcare providers can help in terms of leading the way in message development and delivery. And then as providers, we want to strive to make sure that we have the communication skills that are most effective. So recognizing and respecting patients' concerns, supporting their autonomy and engaging in decision-making that's collaborative, and using some of the skills such as the brief negotiated interview can be incredibly helpful.
So thank you, Dr. Blackstock. We don't have a lot of time, but we did receive a question that I think you're the perfect person to answer. Somebody asked specifically, how do you use these approaches, this sort of motivational interviewing, this elicit, I forgot the second one, elicit, how do you fit those into a short, typical primary care visit?
Yes, that can be some of the challenge. But I think, right now our patients have many concerns and we want to make sure that we're prioritizing their concerns. But obviously having conversations about the COVID-19 vaccine are particularly important. And I think that these conversations, because we typically tend to ask more closed-ended questions, I think getting the open-ended question could result in shorter amount of time for the interaction, because as you ask the open-ended question, you're getting lots of pieces of information from the patient and that will allow you to really focus your conversation. And so I think it can be really helpful just sort of following those steps, just asking if permission, asking about what the concerns are, what the benefits are based on that conversation, sharing information with them, asking, has the information, influenced or changed their thinking? And then finally asking, sort of seeing where they are in terms of their willingness. So I think just sort of following those steps and being systematic about it can help to really sort of focus the conversation and help to really expedite it.
I think I heard you say two things. One is it may not take as long as people think. And then the second point you made in that example was also that people can use their ancillary staff, their nurses, et cetera, to help them reinforce and follow up. It doesn't all have to be on the physician.
That's a great point. Yes.
So thank you. I think we are close to the end and I need to turn it back for the final assessment.
Well, thank you so much to Drs. Harawa and Blackstock for that wonderful presentation. And it's so good. I just want to go a little bit overtime here and just incorporate a few more questions from the audience. One thing that kind of comes up is, what can patients do? Given that some of these barriers have not gone yet and they're not going to go away overnight, what advice would you give to patients? Because of course, all of us, every person involved today is also a patient, in addition to our other roles in society. So what would you say about overcoming these barriers?
Yeah, I can give at least a partial answer to that. I think it's really important, if a patient feels uncomfortable going into a healthcare setting, to be as prepared as possible in advance, to have a succinct description of what's going on with them, a detailed history, bring their medications or have a list of that information so they're as prepared as possible and can use that time as wisely as possible. I would also encourage people, especially people dealing with more serious conditions, to sometimes bring someone else, if there's a trusted family member or someone else that you trust, especially if they do know something about healthcare, they can also help and speak up and ask questions that you may not be able to ask. So those are the first things that come to mind. Do you want to add anything?
Yeah, that's exactly what I was going to say. Just making sure you do your research and bringing other folks who can advocate for you or be a second set of ears. So completely agree.
And finally, if you do go to Google, please use trusted sources. Don't believe everything that might pop up.
Thank you so very much to Drs. Blackstock and Harawa for that excellent presentation. And thank you to our listeners for joining in. As a reminder, to view the full COVID-19 Racial Disparities program on the Clinical Care Options website, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.